All right, we do want to end on time, so probably we can get started and wait people to come in. And hi, everyone. Welcome to this session. I'm Chen Lei from Vital Strategy. I'm a technical advisor with Vital Strategy supporting Data for Health initiative implementation together with our partners, including ISCAP. And I'm very happy to be the moderator for today's session, namely climate change and mortality. As you may all know, climate change can affect our health in many ways. Existing health risks are intensifying and new threats are emerging, including those related to air quality and extreme weather. Importantly, not everyone is equally at risk. Vulnerable population may be disproportionately affected and further widening the existing health inequalities. Why mortality data is crucial for health impact estimation because it provides fundamental evidence on causes, timing, and demographics of deaths. The estimation of the association between climate factor and air qualities with mortality is often complex because it could be a representation of a combination of immediate and intermediate and long-term effect. And it could be both direct and indirect. Understanding these patterns and quantifying impact are critical for designing effective interventions. And this is where the mortality data and analytics and strong public health system play a crucial role. So today we are very happy to have a wonderful group of young researchers presenting their work on quantifying the impact of climate factors and air quality on health. So let me introduce them to you. Our first presenter is Li Qi from Shanghai Municipal Center for Disease Control and Prevention. Li Qi is a public health physician at the Shanghai CDC, where he leads the death registration data quality control for 25 million residents in Shanghai. And his research focused on leveraging CRVS data to analyze environmental risk factors and population mortality patterns. And he was a participant in CART cohort 1, and he has published findings from his work in the SCI Index journal. And his topics today is extreme temperature and cardiovascular mortality findings from civil registration in Shanghai, China. Without further ado, I'll pass the mic to Li Qi, please.
Okay, thank you, Dr. Chen Lei. Hello, everyone. I'm Li Qi from Shanghai CDC, China. And I see many old friends from the CART cohort 1 and the freshmen from the CART cohort 2. Thank you very much. And my research focuses on the association between extreme temperatures and cardiovascular disease, the CVD mortality, using death registration data from the civil registration system in Shanghai, China. As the first practitioner in this session, I will elaborate from the relatively comprehensive perspective. Notably, this topic is designed during the CART cohort 1. And why this topic? The GBD 2025 study shows CVD is the leading cause of death globally and in China. And meanwhile, non-optimal temperature is among the top 10 mortality risk factors. This motivated us to explore their association and relationship. And also, previous studies have shown significant regional differences and specific in the association due to a variation in climate, in the population, and the socio-economic conditions. Therefore, it is necessary to generate reliable epidemiological evidence using local data. So this study relies on the established civil registration system in Shanghai, which currently records every death and its cause in death in the megacity in 24 million people. And we extracted the death records between 2015 to 2020, categorized them into 4 subtypes via ICD-10 codes: is IHD, HS, ischemic stroke IS, and the CSE, the sequel. And daily mean temperature, relative humidity, and air pollution data, PM 2.5 data, were obtained from the national platforms as covariates. Also, for statistics, we used the distributed non-linear model, which has been widely used in this field. It used a cross-species matrix to characterize the non-linear exposure response and the lag effects. Our key results: exposure response curve between the mean temperature and the CVD mortality generally shows an inverted J shape, with the minimum mortality temperature, the MMT, between the 20 to 28 Celsius degree. And we also analysis the relative risks on different lag days after extreme temperature exposure. Extreme cold effect appears 1 to 2 days post-exposure and persists over 2 weeks for most CVD subtypes. And in contrast, extreme heat impact is acute. We observed a mortality harvesting effect in total CVD, females and elderly, and IHD patients. It means extreme heat advanced deaths, otherwise occurring in 1 to 2 weeks. Here, the AI visualized our main findings, including lag structure and vulnerable population differences. And this study offers key accommodations, most notably, and global warming, cold-related health risks still can't be ignored, and Shanghai needed to pay more attention to the act on cold-related health hazards. Also, our work demonstrates CRVS data's value, with high-quality data delivers more precise evidence. Also, the further research could use CRVS data for individual level analysis and predict health outcomes under different climates. Also, as environmental health research is highly regional specific, Shanghai's results may can't apply to otherwise other cities or the regions, but methods can universal. Thus, global collaboration is vital for global health protection, and I'm looking forward to the next few practitioners from different scales and different regional. So deeply thanks to the practitioners contributing to Shanghai's CRV system, and Dr. Roman, Ms. Guzhen, and Dr. Chen from Vital Strategies, and especially the ESCAP CART Cohort 1, Mr. Nicholas, Ms. Nicola, and Ms. Petra. Thank you all for listening.
Thanks, Li Qi. So, well, the presentation was impressive and quick. So we have a few extra minutes. So if anyone has any question, you can ask now.
Thank you for a very interesting presentation. So my question is regarding the lag effect that you were talking. So exactly, maybe the slide went on too fast. Yeah. So are you talking about the number of days or years? Because because the cardiac effects, it take a long time to occur. So do you think if it's extreme cold, are you what kind of serious events are you talking about? Is it an MI, myocardial infarction event, or what are the exact detail of? If you could just highlight those. Thank you.
Okay, thank you. I think I'm too quick to introduce my study. So I calculated the daily CVD death numbers with the daily average temperatures. So use the death time, and the temperature data is also the average temperature daily. So this is not a year, it's just a day. From the day 0 is the exposure day. This is extreme heat in the day 0, and the like day 5, it means after the exposure of the extreme heat. So I think it's not a very specific scale of the temperature. You know, the temperature is different in the daily and in the night, and it's also different in the autumn, in the spring, in the summer. But I think the scale in the day is operator in most regions to do this study.
Just to be clear, so what you're calculating is that, let's say on first December you reached a temperature of -1. So after the effect would be studied on the 20th, December. Is that what you were saying, or you are studying the effects on 1st December and you are calculating the number of hemorrhagic strokes that occurred on 1st December? So just if you can explain it for my understanding only. Thank you.
Okay. This is a question about the model I used. It's a distributed nonlinear distributed lag nonlinear model. This model can combine the nonlinear correlation with the temperature and the death with the lag effect together. So use this model, I can examine the exposure day, how many people deaths, and before the death, before the you mean April 1st day, there's occurred 100 deaths, but with extreme heat, it occurs in the day before this, about the 7 day, a week, 1 week. This model can calculate this lag effect.
Did your question get answered?
Yeah, thank you. It's almost clear. I had similar question, but you already respond to her question. But yeah, I turn to. I just want to know if you have information that those who have affected from the heat and categorized by symptom or death certificate. Do you have any information for those who have preventive practices to prevent heat stroke and those who have severe and death that can be linked together? I mean preventive practice among the data collections for those who has certificate of death or affected.
You mean behavioral type of preventive factors, right? Mm-hmm.
Oh yes, I think in my study, I think it's comprehensive perspective. I think I use the daily temperature in the whole Shanghai city. It's a very big city, but and the new study in this area is the individual level, but my study is in the whole city level. The daily death with the daily temperature is so it's not enough evidence, but it can provide significant evidence, because in most regions or countries they don't have the fine scale data to do the individual study, but my study can give them a confidence to use the same methods to just do use the raw data to do this study. They can get the significant evidence by using their local data.
So another question, sorry. So your I understand that your study is a population level study and not an individual level study. So in population level studies, we have problems like there are confounding factors are there. So if you could throw some light on the confounding factors that you think could be affecting those results, and how did you take them into account in your study? Thank you.
Okay, in the same study, they also use the air pollution data as covariates. They have more and more confidence about the temperature with the death, the medical service, and the age, and the more and more. But in this environmental death and health study, we usually use the air pollution data as a covariates. And I think in the next, my colleagues' study, they will introduce the same thing.
Thank you. So did that address your question? Thanks. So if we don't have further questions for now, we can move on to the second presenter, and then we will have opportunity for more Q&A at the end of the session. All right, so our second speaker is Jing Shan. Jing Shan is a statistician at the Shanghai Municipal Center for Disease Control and Prevention, where she manages and analyzes birth registration data to support public health decision-making. And she's a member of 2024 to 2025 cohort CART program, and her research applies CRVS data to investigate the impact of environmental factors such as climate change and extreme temperatures on urban population health. And today, her title is Decadal Decline in Heat-Attributed Excess Mortality and Evolving Population Vulnerability. Evidence from a neighborhood scale study. Yep, pass it over to you, Jingshan.
Good afternoon, everyone. I'm Jing Shan, a scientist at the Shanghai Municipal Center for Disease Control and Prevention. My daily work focuses on the vital registration data, essentially make sure birth records are accurate, timely, and complete. Today, I'm very excited to share my study, Decadal Decline in Data-Related Mortality and Evolving Vulnerability, a neighborhood scale study. So why did we do this study? The motivation comes from a critical public health question against the backdrop of global climate change. How has extreme heat affected population health over time? Is the situation getting worse, or are we actually making progress? And perhaps most importantly, if there is improvement, does it benefit everyone equally? As you can see from this slide, we are facing two convergent challenges. First, the increasing frequency of extreme heat events. Second, more people are living in the urban areas, which of course also worsens the urban heat island effect. These two factors together amplified the heat exposure risk for urban residents. Shanghai, as one of China's largest major cities, offers a perfect catch to explore this. Over the past decade, we will see rapid urbanization, aging populations, and major infrastructure development. So what happened to the heat-related heat burden? That's the question we want to answer. Let me walk you through our study design. Due to the data availability, we used a two-period approach, compared 2009 to 2011 with 2019 to 2021. We covered all 211 neighborhoods across Shanghai at neighborhood scale, focusing on the warm stations. And here's why this matters. Heat exposure can vary dramatically even within the same city. Downtown might be scorching while suburbs stay cool. Our fine-scale data capture this heterogeneity. For the statistical modeling, we use a two-stage approach. In stage 1, we applied distributed laser nonlinear models to capture the nonlinear and regional effects of temperature on health. In stage 2, we used the multivariate meta-analysis to pull the estimates across neighborhoods. To quantify the healthy burden, we looked at two outcomes, year of lost price and annual exercise. We also stratified the analysis by sex, age, and education level to see how vulnerability patterns differ across population subgroups. So are we making progress? The answer is yes, but not for everyone. Let me show you what we found. First, the big picture compared to 2009 to 2011. The impact of its waves on year of lost was both smaller and shorter, lasting in 2019 to 2021. The average years of lost price dropped it from 1 year to just 0.19 years. That's a more than 18% reduction. Similarly, any exercise contributable to heat waves fell from 327 to 62. But when we dug deeper, two different patterns emerged, and they tell very different stories. Pattern 1, for year of lost, younger people, those aged 0 to 64, and the individual with low education levels had higher losses price compared to older and higher education groups. We also observed a gender shift in vulnerability. In the first period, males had a higher year of loss, but by the second, YL vulnerability shifted to females. Pattern 2, for annual exercise, there was more stable. Males, old age, and low education groups constantly had higher exam mortality across both periods. Those are the findings. Now, what do they actually mean? The primary conclusion is encouraging. We observed a decade-long decline in both age-related attributable years of loss and the excited mortality burden. This shows that adaptation is possible, likely driving by raising incomes, advance in medical knowledge, and infrastructure improvement. The second finding warrants caution. Despite overall progress, these patterns persist. The elderly and low education group remain high risk. This population might have less adaptive capacity, whether due to the physiology, limited current access, low healthy literacy, or weaker social supports. Most strikingly, we observed a gender shift in the viral vulnerability from males to females. This must reflect differences in heat exposure, daily routines, or even how bodies respond to heat. Definitely something worth exploring in future, I think. What are the implications? For Shanghai, our funding provided that driver support for differentiated heat waves protection strategies. It also offers a replicable frameworks for applying CRVS data in other Chinese cities and serves as robust empirical evidence for similar urgent cities worldwide addressing climate-related public health challenges. So based on what we learned, what should we do? I'd like to offer two recommendations for moving towards a precision, equitable, and sustainable heat health protection system. First, targets the vulnerable. We need differentiated interventions for high-risk groups, specifically old adults, low education populations, females, and other vulnerable communities. Second, design for equality. We need spatial planning that addresses the urban heat isolated effect and promote health equality, not just heat warming, but where we plant trees, where we locate cooling center, or how we ensure vulnerable neighborhoods have the results they need. I would like to express my sincere gratitude to Romanization Guzhen and Chen Lei from Vital Organization for their valuable support. Special thanks also go to the United Nations ESCAPE and the 2024 CAT initiative for their guidance and assistance, which greatly contribute to this study. That concludes my presentation. Thank you for your attention.
Thanks, Jinshan, for the very nice presentation. So did you also use AI to create some of your pictures? Yeah. Nice. All right, so the floor is open for questions. Yeah, anyone? Yes, please, if you, right, please.
Okay, thank you so much for your presentation. So you mentioned in your, I think in the conclusions slide, that you saw that the heat effect shifted from males to females. So why is that so? It gets me thinking, why has it shifted? Was it previously more females, more males were working outside, and currently is it the work structure or the professions that have changed? Thank you.
That's an excellent question, and one we are still exploring. Our hypothesis is that it reflects a combination of factors, changing social roles, differences in occupational exposures, and possibly physiological differences, but we don't have a definitive answers yet. Definitely something worth dig into future.
Can you highlight more on the change of professions that you were talking about? What professions now the females are adopting, which were not previously so?
With indoor, outdoor, outdoor，
这个性别的转换的话，是不是和你刚才说到和职业相关？然后的话，这个就是女性是不是从业的这个分布上也有一些改变呢
？Because we don't have the data about this, so I think if I have the data, we will explore this in the future.
I was just thinking, though, just in following up on Amna's comment, is that also that shift between age, the two might be linked as well. It might because there's also sex affects the age of death, and so you're seeing a shifting in age as well. Do you think the two are linked, or are they separate and independent of each other?
We used two outcome year of lost price. It may forcing on the life lost, and we know the younger people they may year lost more, and older people may when we died the year lost is small. So our two outcome may be show the different age group, different age group be as the high risk group.
So I understand this is different measurement used for the estimation, right? Year life lost and excess death. So it depends on the priority, the planning purpose. If you want to plan for reduce the year life lost, then younger age group is the focus. But if you want to, focus on the excess deaths, then the older group definitely has still has a higher excess death. Yes, please.
It's okay, just to follow up on that then. So if you're doing years of life lost, and a man and a woman die at the same age, the years of life lost will be greater for women than for men. So it could just affect. I mean, I understand what you're saying, that it depends what you're looking at, but just to understand the model you used, that would be the case, right? So it would be Y and L will be higher for two deaths at the same age for women than for men.
The year lost is calculated based on life, except expectancy at the age of death, since female live longer than males. Yes, but death at the same age results in more years lost for females. Explains why even though males had more excess deaths and female end up with higher total years lost.
Yeah, thanks. Exactly confirming Petra's point. Yeah. Thanks. All right, so then it's time to move on to the next presentation. Our next presenter is Jiahua Xu. Jiahua Xu works at Ma Anshan Center for Disease Control and Prevention. It's also known as Ma Anshan Institute of Health Supervision. She is a senior public health physician. She obtained her master's degree from China Medical University in 2022. Her work focuses on the prevention and control of cardiovascular and cerebral vascular disease. She is in charge of a weight management program involving 316 participants. And her topic today is lagged effect of PM 2.5 on cerebral vascular mortality in Ma Anshan during 2018 to 2024. It's a distributed lag nonlinear model analysis. The floor is yours, Ms. Jiahua.
Thank you, Dr. Chen. Good afternoon, everyone. Good afternoon. I will not read my title. And I need you to mark the green one. Thank my Thai friend for helping me add Chinese to the title. And then the photo in the right shows my workplace, where I have a strong sense of belonging. Let's see the introduction. Last year, I hiked in Ma Anshan Park with my fitness friend. The weather was nice, but the surrounding factories kept meeting West gates with an unpleasant smell. This experience made me reflect on air pollution and its healthy risks from a professional perspective. PM 2.5 is a global public health threat. Its WHO guideline is 5 microgram per cubic meter. Yet most people worldwide are exposed to higher levels. PM 2.5 is closely linked to cerebrovascular mortality, the leading cause of death in China. Ma Anshan is a typical industry steel city. Its average PM 2.5 level reaches 37.91 microgram per cubic meter, far exceeding the WHO standard. However, relevant systematic studies here are still lacking, so my study aims to fill this gap. Next, I will introduce my research method. First, the data source. I collected 3 types of data: air pollutants and meteorological data, including PM 2.5, PM10, temperature, humidity, wind speed, and so on. And from government, and I download from the government website. All cerebrovascular mortality cases in Ma Anshan extracted from the population death information registration system, covering sex, age, cause of death, and death time. For statistical analysis, I used the 2-core method. Spearman rank correlation analysis is used for correlation analysis, and the DLNM is used for lag effect model, sensitivity analysis, and stratified analysis. All analyses were completed in R software. And now let's see the results. First of all, I'd like to add a point. Ma Anshan is located in East China and features a subtropic monsoon climate with district 4 seasons: cold winters and hot summers. Look at picture 1. PM 2.5 concentrations showed a clear seasonal pattern with higher levels in winter and lower levels in summer. The interannual trend remained relatively stable throughout the study period, indicating consistent seasonal fluctuation. And let's see the second one. Based on the criterion, humidity, mean temperature, and wind speed were selected as the meteorology confounders for the main analysis, and other was excluded because they did not meet the inclusion criterion or showed high correlations with the selected variables. And the third result is about the model diagnostic demonstrated a good model fit, which supports the reliability of my study. And now let's move on to the core findings of my study. First, we found a positive association between daily PM 2.5 concentrations and the relative risk of CVD mortality. The risk increased as PM 2.5 levels rose. Second, in the right picture, the cumulative adverse impact of PM 2.5 on mortality grew with longer lag days with a cumulative relative risk of 1.036 per 10 microgram per cubic meter increase. In contrast, single-day lag effects quickly diminished, showing that cumulative exposure rather than one-day exposure drives the healthy risk. Finally, the higher PM 2.5 levels and the longer lag duration were linked to the elevated risk, while low concentrations and short lag showed minimal effects. And then sensitivity analysis used two pollutant models confirmed that the cumulative adverse effect of PM 2.5 on CVD mortality remained statistically significant and robust after adjusting for 3 air pollutants individually. Stratified analysis showed the PM 2.5 exerted a stronger and significant harmful effect on cerebrovascular mortality under low temperature. And then I have two discussions. This study provides robust evidence that short-term exposure to PM 2.5 is associated with a significant cumulative increase in CVD mortality in Ma'anshan, China. And then the effect is worsened during periods of low temperature, highlighting a vulnerable subground and a potential target for joint intervention strategies. Sorry. And then is the next steps. Before this one, I want to say something. After my elevator speech at the workshop 2, I adjust my next steps. I have 4 suggestions. Number 1, a suggestion for Ma'anshan Ecology Environmental Department. I want maybe the lower the emission threshold for industry waste gas. The current standard of 20 milligram per cubic meter may be too loose. Number 2, recommend environmental it recommend about the stress and law enforcement and standardize the measurement of waste gas emissions from factory. Number 3, encourage residents to take public transportation and make great use of clean energy. And then, just like the slide, and I want to say my thanks to many people. First and foremost, I want to thank ECA, eSCEPT, CRVS, and Maanshan for their invaluable support, which laid a very, very big foundation for the company of my research. And then is Xing Xiuya and Lisa for their professional guidelines, insightful suggestions. And my deepest appreciate goes to my team and all of you here. Maybe someone in another room. Last but not least, I want to introduce my team to everyone here. This is a group photo of my department taken during the 2025 Spring Festival. From the left to the right in the photo are Elder College Zhang Yan, and then is myself, and Dr. Qin, who has a sweet teeth, and the lovely Meng Na and Dan Dan. We are just like a family. That's all for today. Thank you for your patience and attention.
Thank you so much. That's really lovely and also scientifically quite strong. So yeah, the floor is open. We may have time for 1 to 2 questions.
So from your research and of Maanshan and the Liqian Jinshan's research from Shanghai, do you have any differences of your results that that we could compare that Shanghai has what kind of characteristics and Maanshan has what kind of characteristics results? What's the difference?
Maanshan is a still city. In my first workshop, I used a video. Ma Gang, and she's alive for 70 years in Maanshan, and the pollution maybe is green, but I think after 70 years, I don't know how to say, maybe. And just as the picture in the beginning in the industry, there are many industry around the mountain.
So my next question is, as you said, Maanshan is a city of steel. Maybe they will influenced by the air pollution of the steel productions. So do you have any policy recommendations to the whole city?
I have a step about the material, about the consistent of the PM 2.5. My workplace have an article about this, but it was not very clear about the original. Just the PM 2.5 have many consistent. Maybe it's from the car or factory. They are different, and I wanted to figure out in the next step, figure out the consistent and the where is the range? Orange.
Source, origin of the PM 2.5, you mean? Yeah. And you also mentioned you wanted to lower the standard for emission of PM 2.5, right?
Because the public country's standard is 30 and Maanshan is 20, but I think it is still loser. And maybe the factory is more and the standard is lower for the factory numbers.
Got it. So the higher the higher the standard, the more strict is the control over emission, right? Do I understand it correctly? Or lower should be better? Lower should be better, but Ma'anshan is already lower than the national standard.
It's lower, but I don't think it's not
Low
enough.
enough. Okay. Okay, very ambitious, and yep, that's the way to go as a public health person. Yeah.
I'll have a question. So you recommended that when the PM 2.5 is at a certain level and a temperature as is low, the emergency responses need to be initiated. So what are the numbers that you recommend? Like if I am working in health and or I am a policymaker, so what number, like what you would say, what number would you recommend that below this number or above this number we should have the services activated? I'm talking both for the temperature and for PM2.5. And what is the intersection? Because there are different things that are going on, but there's obviously interrelated. Thank you.
I know the WHO standard is 5 microgram per cubic meter, and our country has a standard is 30. And I think in Ma'anshan, maybe it should be lower because of too many factories. But it's a little hard for me to choose which number the policymaker to choose. A little hard.
But the policymakers usually they require numbers because they need your suggestion. So
Maybe it should be connected with economy.
Yeah, that's a very good response. And yeah, we have one more question. So yeah, please, after this question, we will need to move on.
The presentation was brilliant, and I enjoyed it because from my infrastructure perspective, when you did your study, there's two types of environment. There is the internal air quality and the external air quality. And I noticed you recommended some sensors to collect some data in the city. And my question is quite simple. In the province you're in, do they have any plans to improve the city's infrastructure to tackle the pollution?
Thank you, Johnson. The first, in my mind, I can always see the cleaner on the road. They just use the water in the air, and the speed of PM 2.5 to the place or to the plant. I think it's to the plant. The speed is more quickly. It will be less in the air. So this must be a good idea to increase the cleaner or the bus who has a bottle of water in his behind, and just aid the air humidity. Humidity. Yeah. Thank you.
Thanks. So with that, we will move on to the next presentation. So next, we will have a team. The Thailand team with the heat tag is consists of 3 presenters, including Nantanon Disakontaravaji and Visawat Malakan and Ying Mei Tun. They are researchers from HEATAP. Sorry, I don't have a full name here, so please, can you say your full name later? And HEATAP is from Ministry of Public Health, Thailand, And they support research and policy initiatives that strengthen the environmentally sustainable and climate resilient health systems. And their work focus on the intersection of climate and health, and particularly on mitigation and adaptation strategies to reduce environmental impacts and address the effects of climate change on human health. So today the team's topic is association between ambient temperature and chronic kidney disease mortality in Thailand, a nationwide time series analysis. So the floor goes to the team.
Good afternoon, everyone. So we are the Thailand team. We're from Environmental Economy Unit, as HITAB is a Health Technology Assessment Foundation program in Thailand. So our study for today, our study for the presentation, associations between ambient temperatures and chronic kidney disease mortality in Thailand, is a nationwide time series analysis. Okay, so before we get into the studies, I would like to acknowledge ECA, SK, organizer to make this CRVS training possible, and everyone in the team as well. And our study will not complete without the support from NXPO and TSRI Thailand as well. Okay, so we'll start with the study. So chronic kidney disease, or CKD, is a long-term condition where the kidneys gradually loses its functions over time. So the patient will eventually need a dialysis treatment, so which is very expensive and time-consuming for patient as well. So our workplace, HITAB, we work a lot on this topic. We are well recognized for CKD policy and researchers in Thailand for many years, and we're still working on this work right now. So in Thailand right now, there are 11 million people who currently have a CKD disease, and around like 150,000 patients are having a dialysis treatment. So because of this growing demand, there are also like increasing number of dialysis center around the country nowadays. As you know, dialysis treatments, it can be very resource intensive. So it also have an environmental impact as well, like producing a lot of carbon emissions, indirectly like impact the climate change as well. So there are like many causes of CKD, and recently the unknown cause of CKD has been gaining more attention, and studies have shown that this unknown cause of CKD is caused by environment and occupational heat exposures. And as you may know, Thailand is very hot. You're probably experiencing this right now. And it has been like, the temperature has been increasing every year and has been impacting like people's health every year. So because of this, our research question is we want to know how these temperatures influences the CKD. So our objective of the study is to examine the associations between the ambient temperatures and CKD mortality in Thailand. So the insight from these studies can be very helpful to the development of health preventive strategies, especially the one the MOP and Nephrology Society in Thailand has been doing, and also can provide evidence for occupational health policies and ultimately support in the development of early warning system in Thailand. So before to do this study, we have to talk about the methodologies and how we collect the data.
Okay, let's move on to the methodology. So, starting with the data, we use a 10 years longitudinal monthly data set covering January 2015 to December 2024. We collect the data from Ministry of Public Health Thailand, capturing all cause deaths caused by CKD under ICD-10 code N18.0 to N18.9. So over this 10-year period, we record a total of around 8,600 deaths nationwide. And for our climate data, we utilize the ELA5 land reanalysis dataset, which we validated against Thai provincial methodological station data with Pearson correlation quite high, 0.83. And yeah, the data overview, we use the data across Thailand from 77 province, and this include 10 years, which is 20 months. Total observation is 9,240 with no missing data. So next, the method we employ the two-state time series analysis. With state 1, we do analysis with provincial analysis. With we employ Poisson ligation for each province and to estimate the association between temperature and CKD mortality. We also confound by seasonal pattern, which is a month fixed effect, and relative humidity as well. For the second one, we pull the data from each province that so we can do the meta-analysis, which is a random effect meta-analysis to obtain overall effect and represent Thailand. So this our equation look like. We can go back if you're interested in, but I will skip it. So the first result.
Okay, so the first part of the results will be just descriptive results. So the results when we show how temperatures trend change in Thailand over the past 10 years. And you can see these two graphs. We have divided into like periods from 2015 to 2019, and then from 2020 to 2024. You can see the average maximum temperature has been increasing in the previous year. If you can see it clearly in the pictures, yeah, it's getting more hotter nowadays. And next is the mortalities of the CKD disease. So figure A show the region distributions. You can see the disease has been like impacting the whole regions of Thailand, and the mortality data are unevenly distributed, especially like a lot more on the northern, northeastern, and the central areas of Thailand. And there are around like 8,593 dead from CKD in Thailand. So the results tree is just to compare the monthly deaths and the temperature comparison over the past 10 years. And you can see that in the month of March, April, and May has the highest temperatures and also highest rate of death in Thailand. So which is right now is the summer periods. So right now is the summer periods in Thailand is the hottest month.
Thank you. For the next result, you can see the average temperature distribution in Thailand, which is I put the frequency, the temperature in Thailand in the left-hand side, and I put result for meta-analysis to be in the right-hand side, which show the exposure response curve. And yeah, as you can see, it's quite go like exponentially. And for example, if you can see percentile 90, which is 29.1 degrees Celsius, with RR with 1 to 0.29, and if the temperature hits 30 degrees Celsius, its RR is 1.46, and if the temperature like skyrocket to the 35 degrees Celsius, the RR is almost 3 times risk compared with the reference point. So even we present that, but we also have limitation. First, as I presented before, this is limited to the monthly data. So we might cannot use like lag effect, something like that, which is quite not make sense to like affect this month to the next month. And the second one, we lack of the individual level data, which is if we got this one, I think we can separate characteristic and see whether male or female, like how the different of list should be. And the third one, yeah, absolutely, we may uncover the unmeasured confounder or something like that. So the last one is ICD-10 code, which is may not like accurate that we hope. Yes.
Yes, for conclusion, so the higher temperature linked to the, for sure, increased CKD mortality in Thailand and mortality peak in hot summer. So that we got it. And regional different second unequal vulnerability, different provinces, different exposure. And the finding support public health planning, something like early warning system, improve prevention guideline. And for the recommendation, we support MOPH to indicate temperature related risk into the national health policy, or in Thailand we call HNAP, and CKD surveillance system. And we also support government to develop and strengthen health early warning system. Right now we having the air pollution early warning system, and we have the heat, but I think we can improve the system. And we can implement the targeted intervention for the high-risk population in the high temperature area. And the strength healthcare system prepared during the hot season. Right now, Thailand having, especially for Thailand, we having the intervention we call the clean air shelter, or someone we call BKK air cooling center. So everyone can access there in the room, having the free aircon. Everyone can access it. Eventually, a vulnerable group. So it's quite good for Bangkok and Thailand. And we would like to thank you, organize happen, and lovely colleague and lovely mentor and our team to doing this. And if you have any question about climate and health, please feel free to contact us, HiTap. This is our email. Thank you for your attention. Thank you.
Thanks. You are also a lovely team and efficient. Thanks. So, do we have any question? Yes, please. Yes.
Thank you, Thailand team. You have great presentations, and please be prepared because I have 3 questions, or 4 questions. So my first question is, what's the top 10 leading courses in Thailand? So which leads to why you chose CKD as the goal, not as like others, some cardiovascular diseases. From my opinion, maybe I think it's more linked to the high temperature or the extreme temperature. And the second question is, from my opinion, the Garbage code has a classification that CKD, including the N10 to N18, they are classified as garbage codes. So I don't know, are you choosing the CKD as the underlying cause of deaths, or just the death databases that mention the CKDs, they use the data, you adopted the data. Yeah, this the second question. And the third question is from Dr. Lichi. His question is, your research time periods is in 2015 to 2024. That's including the period of COVID-19. So how do you adjust the effects of the COVID-19's effects? Yeah, that's all my 3 questions. Cool.
So for the first questions, why we choose CKD as a main disease. So to be honest, like this project is our side project that we do in this team, and our for chronic kidney disease is one of the disease that one of the area that our workplace is well recognized to do it, well recognized in doing the research. So HiTab is like leading like institutes that work on like CKD policy and researchers. So we have like a lot of like database. We have a lot of like knowledge on this to also ask the expert from. That's the reason. And of course, there are many top 10 diseases like cardiovascular diseases or like any other diseases that relate to heat. But we start with the CKD first, and then eventually in the future, we can lead to do more diseases. And actually, we're doing a systematic and meta-analysis review on heat and health as overview. And Nongfu here is leading the study too. So yeah. So second question is about the
classification of CKD diseases, because in GBD classifications they are defined as garbage codes, though not so severe, but in the level 3 or 4. Yeah.
Okay. Actually, in our database about that we collect the data, they identify the ICD-10 code that related to the CKD or related. So I might put the wrong number And actually, yes, they already like include all the related CKD. So I think it's fine to like include all already. Yes. Uh, did I answer your question? So
You recruited the diseases that mentioned the CKD, or just the diseases, the underlying course of disease that is caused by CKD, which is
So is the data that we have, the mortality data that we have, and the disease is the CKD, and the code is this ICT-10. So it was in the data set. So we just use it.
May I help here? So the data set you have is coded with only one cause of death, right?
Yes.
And it's got, you receive it from Ministry of Public Health, from SPD, Strategic Planning Division.
yeah, but
Then
this,
that's the underlying cause of death.
yes.
Yeah.
Thank you.
That's the only disease. Yeah.
Okay. Yeah. Sorry, I'm working to support the CRVS program in Thailand. So sorry, I have the background. SPD is in the unit in the Ministry of Public Health to code the data and select the underlying cause of death. And yeah, but you may want to go back and check whether they use the data set from the MCCD, Medical Certificate of Cause of Death, or they include both the facility deaths and community cause, because the data quality are different. These two data sets, the data quality are different. Yeah.
Oh yeah, thank you. Thank you for the suggestion. Yeah, we will go back and check. And the last question is about
you mentioned that your research period is in 2015 to 2024.
Yes.
That's during the period of COVID-19. So how do you adjust the COVID-19's effect?
Yeah, thank you. This one we already try to cut the period with COVID-19 and without. We saw that CKD death is not different. So we just use this period without like consider that. But actually we try to check the sensitivity analysis with cut the period without with COVID-19. Yes. Yeah, I think because it didn't like affect like each other. I mean, COVID-19 didn't lead to the CKD, something like that. But yeah, maybe it's a cause.
Okay.
Yes. Please feel free to ask more. Yes.
Okay, thank you.
We have 5 minutes. If there's more question, yeah, please.
I would want to find out what is the death registration completeness rate.
registration completeness rate.
Oh,
Death registration completeness rate for
for Thailand?
Yeah.
Okay. Yeah, it's actually it's quite good, but with that data, we have a lot of unknown data, the unknown cause of death, which is we like my cannot accept that one. Actually, I present a number at 8,610 year. This data might not make sense like to show it's only like 8,000 people die within 10 years, right? Yeah, a lot of people like maybe die with unknown cause, which is maybe it's kidney disease. Yes. Yeah.
So just to follow on that, I'm just thinking that you've got 10 years and you don't have actually that many deaths, but over those 10 years, you've got increasing temperatures, but you've also got improving, I hope, quality of cause of death reporting. And you'd also have maybe an aging population as well. I don't know how much that would affect in 10 years, but those trends might be leading to maybe your findings being overstated, possibly. I don't know. Do you?
Yeah.
Yeah.
Yes, I think that's a great question, and yeah, we try to consider all of the effect that lead to the kidney cause. Yeah, but with our application with data access. Yeah, maybe we can do like this for now. Yeah, maybe after we got the data from SPD that Dr. Shelley just suggests, maybe we can explore more. Yes.
Thank you. But yeah, well, I'm not at the position to promise that you will get the data, but I'm happy to connect you with the SPD and MOPH responsible unit if needed. Yeah, and with that, so we will move on to the next presentation, and please the team be seated and wait for the Q&A session at the end. Thank you very much for your presentation. All right, so sorry, a 1 minute introduction. So our last but not least presenter is Dr. Zhiyu Yang. Zhiyu Yang is with the Shanghai Municipal Center for Disease Control and Prevention, and she is a public health physician and researcher and a fellow of the CART program supported by UNESCAP and ECA in the current cohort. She has published as the first author in the peer-reviewed public health journals and brings both statistical and epidemiological expertise to her work. And today, her presentation will be on evaluating the impact of air pollution control policies on birth defects in Shanghai during 2028 to 2019. Yes, please.
Thank you, Dr. Chen Lei, and thank you to all the speakers before me. My name is Yang Zhiyu from the Shanghai CDC. I'm here to ask a simple question about when the air gets cleaner, do the fewer babies get sick? And this is my topic. It's about evaluating the impact of air pollution control policies on birth defect in Shanghai. And before I begin, I want to thank UN Escape, the ECA, and the CAR program for making this work possible. And I'm deeply grateful to my mentors, Dr. Liso, Nicholas, Tanya, and Petra. Thank you, Petra. And I will also thank the vital strategists, Dr. Roman, Dr. Gujen, and Dr. Chen Lei, and the Shanghai CDC for data access and support. To begin with the background, Shanghai faces the severe PM 2.5 pollution due to the rapid industrialization and the birth defect as a leading cause of the infant mortality. And against this backdrop, in 2013, China launched its most ambitious clean air policy, which called the APPCAP policy. And Shanghai is an ideal setting, which means the PM 2.5 levels dropped substantially after the policies, and the city has maintained a population-based birth defect surveillance system. And for the CRVS colleagues, we have 2 points of view. First, no registry, no study. And the second, the best screening to find the more cases. But that doesn't mean the more babies are sick. It may be simply mean the doctor are better at diagnose them. And to separate the real change from the detection bias, we use a negative control in our studies. And then extending research had linked the PM 2.5 on birth defect. Many papers established that. And however, important gaps remains. First, the few studies have focused on the Chinese population, and even fewer are asking whether the policy-driven the air quality improvements actually reduce the birth defect incidence. So, taking together, our study focused on the 3 questions. First is the PM 2.5 exposure associated with the risk of birth defects. And the second, did this policy reduce the incidence of birth defects? And the third, to what extent did the APP-CAP policy reduce the PM 2.5 levels? And to answer these questions, we adopted a two-stage analytical framework drawing on the three data sources. First is the Shanghai birth registration data, which included the 2.3 million births daily, and then we have the PM 2.5 data and the weather data. And in stage one, logistic regression estimates the individual level association between the PM 2.5 and the birth defect rate. And the stage two, we applied the Bayesian structural time series model to estimate what the rates would have looked like in the absence of the policy. I want to add some key design for our study is our use of the chromosome defect as the negative control, because these conditions are genetically determined. So the chromosome defect should not be affected by the air pollution. And the next slide is our study population. We included 2.3 million births in Shanghai among 12 years, included about 56,000 birth defects. And in the table, we found that mother of infant with the birth defect tend to be older and more educated and more likely have the Shanghai residence, which we call the 户口. And this likely reflects the better access to prenatal screening, not necessarily high true risk. And across our study period, the screening coverage expanded greatly across the whole population. That's why we use the negative control to separate the real changes in disease from the changes in detection. So it's my main result. Let's move to the result. This figure shows that the PM 2.5 level decline after the policy. The policy is the red line is the policy. And well, the most birth defect categories appear to show the upward trends. This raises a key question. Are we seeing a true increase or simply improve the detection? Because during the same period, the prenatal screening coverage in China increased from about 20 to about 77%. Our analysis is designed to find this, to separate the two possible. And first, looking at the individual level association for every typical increase in air pollution levels, the risk raised by the 6% in the all birth defects. And importantly, chromosome defect shows no association like the green one. And this exactly what we would expect for the genetically dimension conditions, and it supports the validity of our negative control strategy. And come to the time series model. On the left, after the policy, we found that the nervous system birth defect decreased by one per 1,000 births. And on the right, the PM 2.5 concentration dropped from the 52 to 37 units. Now an important question. Could this simply reflect better screening over time rather than the true reduction in disease? To address this, the chromosome defect played two roles in our study. First, inside the BSTS model, their monthly trend was included as the covariates, helping the model distinguish the true policy impact from the gradual improvement in detection. And second, we run the BSTS model on chromosome defect as an independent validation, since they are genetically determined and cannot be affected by the air quality. We expected no policy effect. The result confirmed exactly that. And the questions we asking is simple. What would have happened if the policy had never been implemented? And the green, I'm sorry. The green line showed the observed incidents after the policy, and the red line shows what our modules predict would have happened without the policy. So after the policy, the green line falls constantly below the red one. And then let me now bring the three questions together. First, did the policy improve the air quality? Yes. We found that the PM 2.5 concentration dropped from the 52 to the 37. And number two, did it reduce the birth defect? Yes. Nervous system birth defect decreased by 1 case per 1,000 births. And is the PM 2.5 linked to the birth defect rate? Yes, significantly with the association with the 4 categories. And looking ahead, we have 4 directions. The first, more geocoded exposure assignment, and third and second, linkage with the behavior data, and third, multi-city comparative study and the extended follow-up. And thank you for your attention.
Thanks, Julie. Very interesting study. And previous presenters, they estimate the impact of the air pollutant or the temperature or other climate factors. And you are doing one step further, analyzing or evaluating the impact of the policy, right? Which will already had the effect on reducing the PM 2.5, and then now you also demonstrate the health impact, the real impact on the health indicators. Yeah, very interesting. Thank you. So, yeah, do we have any immediate question for Dr. Zhi? Or we can open the floor for the Q&A for all the panelists. Oh, we have a question. Yeah, please.
Just don't this it did not consider in the question, just recommendation from me. I'm from my area is air pollution. I think for Thailand, we for the factor got the most factor is related to air pollution is meteorological. If we don't include sort wind speed is the most wind speed. It can tell increase or decrease PM 2.5. This and it should in the future, if you could increase this parameter, is very good. And they call having another parameter they call mixing high or mixing speed, high speed mixing high. Yeah, yeah, it's 2 parameter that affect the most for air pollution. Yeah, for Thailand, in case Thailand. Yeah.
Thank you. Thank you.
Thanks for the suggestion.
Yeah.
All right, so then let's move to the Q&A session. So do we have any question? Now is the time.
Thank you for those fantastic presentations, all really interesting. I think one of my questions was touched on by the Thailand team, but I wanted to share to maybe put it out to everyone. You're relying, I think, in all of them on cause of death reporting. Do you think there are any issues with the quality of cause of death reporting that could affect, your study? Either not having cause of death or having garbage codes or having things which are misreported. Do you think that might be an issue? That's my first question. Can I have a second one? Is it okay?
Yes, please.
Okay.
Yeah.
Then my second one was, I think more about do you think we had one study which said actually low temperatures are going to increase the effect of PM 2.5 and increase mortality. Then we've had other studies saying actually high temperatures are going to increase mortality. Given that we're probably moving to high temperatures rather than low temperatures, could we see then declining PM 2.5 mortality? And maybe could that balance out some of the deaths we're seeing from the excess from the higher temperatures? Just wondering if that might be anything that's significant.
Yeah, that's a very logical way of thinking that. So do we have any immediate response? So the first question is about the quality of cause of death. Yeah, we talked about it. And yeah.
Thank you. I think all of us may can add more than me, and I think yes, absolutely yes. It would be affect for sure for my point of view, because you can like just imagine like the people die a lot, but they die in their house and they no one to add their cause of death to be the one they die. So yeah, I think yeah, in Thailand, in case of CKD, I would say we have a lot of silo data source. So the kidney data center, they identify whoever die after like take medical at that station, they will consider to be dead by CKD or acute kidney disease. But in the Thailand legislation system, they consider based on our doctor, and yeah, there is a lot of people that die with unknown cause. Yeah, in short, is yes, totally affect. Yeah, you can add more.
质量会对这个研究有影响吗？死因数据质量。
Thank you. As for my research, I use the daily mortality numbers, so it's a little relevant to the quality of the data. But when we talk about the death data quality, we always think about the cause of death and the underlying cause of death and the cause of death chains. But in my research, I only use the number, daily number. I think in the individual study, it's very important to know the residence of the death and the place he live. It's very important about the quality of the death.
May I clarify? So your CVD, you take you define your number of case by selecting only a certain ICD code, right?
Yeah, only the ICD code from I0 to I99 of the underlying cause of death.
And you think that this ICD code underlying cause of death, the quality is good, right?
Yeah, this is absolutely good.
Right. I think this answers Petra's question, because you are confident with your cause of death data. So your number, yeah, because you anyway need to select a subset, right?
Yeah.
So that number is reliable. Yeah.
Oh,
please.
Okay, I have something to say. In Ma'anshan, my department studied start to make the death registration in 1983, and it has lasting for almost 40 years. And then after my daily work, we always go to the urban hospital, and after our supervising and inspection, we found there is almost no underreporting in hospital, and underreporting is extremely rare in community settings. A few individual cases occur when monkeys pass away. They have special submission procedures for ordinary residents. A death registration certification is required before submission. Therefore, overall, the quality of Ma'anshan death registration is very reliable. That's all. Thank you.
Jianhua, so may I follow up on that question as well? So you mentioned the completeness is very high. 就是那个完整性很好。Yes. So what about the quality of the cause of death data? And do you know what is the percentage of ill-defined cause of death or so-called garbage code if you use different category?
After the doctor write, it will send it to the website, and the CDC worker will correct it if they will do the quality control, and to the Ma'anshan CDC they will do again about the quality control. Okay.
So there are two quality assurance steps in between the statistical data set and the original MCCD. So yeah, the quality should be good. And second question.
The second question, at present, our research focuses on the impact of the single risk factors. Me, Jinshan, and the Thailand team about the temperature, and in this case, we as air pollution as a covariates, and Yang and Jiahua research about the air pollution PM 2.5. In that case, they use the temperature as a covariates. But I think the future and the latest research about the environmental and healthy is about the combined exposure with health care, but it needs advanced model and advanced methods, but it's a trend in the future.
Thank you. And I do want to circle back to the idea our audience had, like, if our policymaker ask for one number, one and only number, will you have any solution to kind of like try to convince your policymaker this is important or this is a time to act? Do you have anything in mind? I know you calculated the risk ratios, and you have different variables, right? Risk ratio for each factor, like PM 2.5, temperature, and other air pollutants. Will it be possible to combine them and make one number, composite like index? Would that be possible?
I want to say about the temperature is fine, but because it's we can't control. It is we can't let it be lower or higher outside the door, but we can choose the number of temperature is can choose, but the number of PM 2.5 must be connected to the economy.
Got it. You're talking about the standard, right? Yeah, standard of the emission kind of allowed limit. Yeah, that I agree. And well, just try to explain in Chinese. Sorry. 就是我们刚才说到那个刚才那位学者就是问，如果是有那个你的政府决策者问你要一个数字，要你一个数字，你不能告诉他你的这个就是危险度是多少，对吧？危险度对他是没有多大意义。然后有没有可能就是用这些危险度你拿来做斜率嘛，对吧？每个你的其他像温度你有值可以填进去，你观测值填进去，但是你知道温度在这个里面起到多大的作用？然后 PM2.5、PM 2.5是多大的作用？还有其他的那些协同因素，像NO2这些，你们觉得这样子可行吗？就可以做出一个数字。
I think Dr. Chen Li mentioned is index. You know, we now have the index of the AQI, air quality index. It contains about 6 kinds of air pollution, about the PM 2.5, PM10, and it divided into the 6 levels. And most of government have look at the AQI as a good index, but I think in the future we will combine some new air pollution content with the temperature, and we should build the new index, but to let the government admit it is difficult, but the research is basic fundamental for this. I think first the paper and the policy.
Okay, thank you very much. So my question, it actually came from because I was outside in Bangkok last night, and I saw there was this PM 2.5 level. There was this board written there. The question is from Thailand team as well. So the level was fluctuating between 25, 26, and 27. So what I thought was, because this was something new for me because it's not in my country. I come from Pakistan. So my thought was that what is the cutoff point where the red sirens start? And so this was actually my question. I'm sorry if I was not clear. So maybe you can answer the Thailand team.
May I clarify your question? Are you asking when the siren will announce, right? Something like.
What is the danger level?
Okay. In Thailand, we have the guideline, but I'm not sure which rate of that one that we announced. Actually, it start from 40 degrees Celsius in term of in term of heat index. Yeah, this one I also answer the Dr. Shelly questions that if we have only one number, which the number that we will present to stakeholder or the policymakers, I think it's heat index. It's not just the temperature that we feel. Heat index include it relative humidity to show what the temperature that we feel. You can check in the weather application in iPhone. That one it's reflect based to show like how you like if your exposure the temperature like ambient temperature outside the outdoor that it's maybe like high risk to you to that one. And the guideline show us the heat index indicator to show like which the number that you should avoid to exposure outdoor temperature. Thank you.
Thanks for that. Yeah. Also, thanks for clarifying the question. All right. So, do we have other questions? Yes, please. We
If
have
there is time.
15 minutes.
I have a question from Yang. When you did your literature review, did you have the same results? Do we have the same results in any other country besides China, where the birth defects have decreased after control of the is there? I mean, I'm not sure if this policy has been implemented anyplace else, but if you have any findings, please let us know.
First, thank you for your questions. And no, we haven't found the other country do the same research, but some country do some research like the air pollution and the birth defect, but the policy-driven air pollution policy and the association about the policy and the birth defect, no. So I think it's the unique study about it. Thank you.
Thanks. So this will be the last session before we head back to the big room for the closing section. So we do have some time for extra questions, like 15 minutes if you want to shoot. All right. So if there's no more question, then we can wrap it up and have an early coffee break section. All right. So, well, today we heard presentations from young researchers from 2 countries, wonderful ones, and they are examining a range of health impacts, leveraging birth and death data, particularly the cause of death and birth defect data. The result help to answer the critical questions like how much the health problem was affected by the respective climate factors or air quality, and how we could control or mitigate the effects, like making a policy to make less defect of babies. Why not? Right, the result helping to answer these critical questions, and the innovation's next steps for translating their findings into further policy recommendations and decision making are both exciting and encouraging. As we move forward, much remains to be done to further deepen our scientific understanding and to translate further the knowledge into action. And I believe the CART initiative is and will continue to be a valuable and wonderful incubator for that. And Vital Strategy has also developed a small training course, specifically focused on the quantifying analytic of the health impact of the air quality and climate factors. So contact me if you are interested in the technical details. And together, I believe we can continue advancing this journey of advocating for cleaner environments and more resilient health systems. All right. Thank you again to our wonderful presenters, and thank you to the audience for your active engagements. And let's give everyone another round of applause before it. With that, we will close the session, and we do encourage you to continue the discussion and conversation with our panelists during the remaining time of the forum or beyond. All right, so with that, thank you everyone again. Enjoy the rest of the forum. Thank you. Oh, I guess the coffee break is ready. So, well, if you still want to talk with the panelists, feel free to do so during the coffee break. Okay.